Good morning. I'm Lisa Parker, Director of the University of Pittsburgh Center for Bioethics and Health Law, and it's my great pleasure to introduce today's Grand Rounds speaker and to express gratitude to the Department of Pediatrics for its continued commitment to fostering attention to pediatric ethics through our collaborative Visiting Professor in Bioethics program. I also want to express appreciation to the spouse and children of Donald Medeiros for establishing the Medeiros Memorial Lecture we will hear today. For those particularly interested in the religious and spiritual dimensions of today's topic, I would invite you to attend the next lecture in our Healthcare and Religion Lecture series on June 1st, when Natalie Ernikoff from the section of Palliative Care and Medical Ethics will discuss referring to chaplaincy in cases of serious illness. Information about that new lecture series is available on the Center for Bioethics website. It's not, and my slides don't want to advance. There, now they do. Donald Medeiros began and ended his medical career at Harvard Medical School. After receiving his medical degree there in 1953, and then after his internship at Barnes Hospital in St. Louis, he completed his residency at Cincinnati Children's, the institution from which today's speaker joins us. Before returning to Harvard Medical School, Dr. Medeiros served as medical director of Children's Hospital of Pittsburgh and professor and chair of the University of Pittsburgh Department of Pediatrics. From 1969 to 1973, he was dean of our medical school. He was lured away to Cleveland and then became the Charles Wilder Professor of Pediatrics at Harvard Medical School for almost 2 decades until his death in 1995. President Carter appointed Dr. Medeiros to his Presidential Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research. Another physician ethicist whom we honor today is my former student, colleague, and friend, Aviva Katz. During her tenure here at Children's as an associate professor of surgery and pediatrics, Aviva earned her master's in bioethics. She directed the Ethics Consultation Service and directed the Center's Consortium Ethics Program. She was a valued faculty member in our Center for Bioethics. She also chaired the American Academy of Pediatrics Committee on Bioethics, of which today's speaker is a former member. A vice chair of the university's IRB, Aviva was also appointed to the Secretary's Advisory Committee on Health Research Protections within the Department of Health and Human Services. She was appointed in 2016, 2 years before her death. Her family established the Aviva Katz Memorial Fund for Ethics in her honor. To continue the legacy of attention to pediatric ethics, which Drs. Medeiros and Katz exemplified and nurtured here at Children's, Dr. Armand Antommaria joins us today from Children's Hospital, Cincinnati Children's Hospital, where he is the Lee Alt Carter Chair in Pediatric Ethics, and he directs the Ethics Center and chairs the Ethics Committee. A professor of pediatrics and surgery, Dr. Antommaria received his degree in medicine from Washington University School of Medicine in St. Louis and his PhD from the University of Chicago Divinity School with a focus on religious ethics. He did his residency at the University of Utah, where he pursued a certificate in conflict resolution and became an associate professor of pediatrics with tenure. I know Armand as an investigator in the NHGRI eMERGE network, the Electronic Medical Records and Genomics Network. You may know him as the associate editor of Ethics Rounds in the journal Pediatrics. His own publications address a range of ethical concerns from visitor restrictions, masking requirements, and allocation of scarce resources during this current pandemic to informed consent, ethics consultation, conscientious objection, religious exemptions from vaccination requirements, and state intervention in parental decision-making. Today, he will speak with us about religion and pediatric medical decision-making. Please type your questions using the Q&A function at the bottom of your screen. And welcome our speaker today. Thank you.
I wanted to thank Dr. Parker for this kind invitation and generous introduction, the Medeiros family, and also express how much I also miss Aviva, and talking with her at the AP Committee on Bioethics meeting and catching up about, her children's figure skating. I have no potential conflicts of interest to disclose, and I will not be discussing off-label or investigational use of commercial products. I think given the topic of today's presentation, that I should disclose my own religious affiliation. So I would describe myself as a generic Protestant. I was brought up in the Protestant tradition, and currently worship at an Episcopal church, but don't have a strong denominational affiliation. And I think it's also worth making an initial comment about terminology. So the language that has historically been used to discuss one of the topics of today would be religion, which would encompass both the personal and organizational and institutional components of the topic. I'd say over the last 30 to 40 years, there's been an increasing trend to differentiate religion and spirituality, focusing religion as the organizational and institutional components and spirituality as the personal and experiential components. And given that I'm going to predominantly talk about religious traditions and their beliefs, I'm going to primarily use the language of religion. I also acknowledge that that language has negative connotations to some individuals, viewing religious institutions as authoritarian or religious believers as self-righteous, and so recognize that that language may create some barriers. So my presentation is going to have three components. The first component is going to be about the importance of religious belief to many Americans and how it influences their medical decision-making. But the relatively high levels of, or relatively low levels of religious literacy with the United States and how that creates problems. Move to a discussion about medical neglect and potential state intervention in medical decision-making, particularly around religious refusals. But want to emphasize that even though state intervention may be justified at times, that patients and their families should nonetheless be treated with dignity and respect. And then the third component is going to focus more directly on accommodations of religious beliefs, with a focus on disputes about the neurologic criteria for death. So this is part of a page that was generated by a couple of providers at our institution around vaccine myths. And it stated that the myth was that COVID-19 vaccines contain human stem cells, and that the facts are that none of the vaccines contain human cells, let alone human stem cells. And the interesting thing to me was that as I was preparing this talk, was watching Last Week Tonight, John Oliver was addressing vaccine hesitancy and stated something very similar, that evangelicals are concerned that the COVID vaccines contain cells from aborted fetuses, which he emphasized was not the case. And for me, this is somewhat emblematic of the way in which religion potentially is addressed in healthcare, in that While there are individuals who would claim, particularly in social media posts, that the vaccines do contain fetal cells or human cells, that's not the dominant concern or the central concern of some religious traditions. And that by potentially mischaracterizing the concern, the FAQ speaks past individuals and potentially creates a problem that if they later find out what the central concern might be, then they might be put off and feel that they were misled. So within potentially the Roman Catholic tradition and the evangelical tradition, the concern is that the vaccines are developed, produced, or confirmed using fetal cell lines. So there are cell lines that were developed using tissue from electively aborted fetuses. The Johnson & Johnson vaccine was developed and is produced with a cell line that was developed from fetal retinal cells in the mid-80s. And the Pfizer and the Moderna vaccines aren't developed or produced with a fetal cell line, but their efficacy was confirmed using a cell line derived from fetal kidney cells in the 60s. And for some religious traditions that see abortion as being ethically prohibited, the concern would be that receiving the vaccine makes those individuals morally complicit with abortion, which should be avoided. And a variety of religious groups have made comment about these concerns. So for example, the Vatican's Congregation for the Doctrine of the Faith has argued that it's morally acceptable to use one of these vaccines if an alternative is not available. And so their analysis is based on the category of cooperation. So within the tradition, there's a distinction drawn between formal cooperation and material cooperation. In formal cooperation, the cooperator shares the same intention as the wrongdoer, and this is always morally prohibited. In material cooperation, the cooperator does not share the same intention as the wrongdoer, and this can be permissible in certain circumstances. And they would characterize the type of cooperation here as remote and passive. So the fetal cell lines were developed in the 60s or the 80s, which are temporarily remote. The recipient of the vaccine had no role in the decision to use these cell lines in the development or the production of the vaccines. Therefore, their cooperation is passive, and that the COVID pandemic represents a grave danger, and therefore using the vaccines is morally acceptable if an alternative isn't available. And the interesting thing to me was then I had a conversation with our communication staff about potentially changing the FAQ or the myths and facts statement. And they preferred not to change it, which I think represents some concerns about entanglement with religious views or perceived endorsement of religious views. But if those types of changes aren't being made, it might be preferable not to say anything. I'd say that there are other examples of other organizations' response. So this is a document from the Michigan Department of Health and Human Services. The portion that I want to highlight is here at the bottom. So it asks, have faith organizations address this, and provides links to both state, national, and international organizations, both within the Roman Catholic tradition, as well as the Lozer Institute represents both Roman Catholic and evangelical Protestant views. They're not actually summarizing the conclusions of any of these bodies, but providing individuals potentially reliable sources of information. And I would say the strengths of some other state agencies. So the Oregon Health Authority has a really nice document for Muslims who may share similar concerns. And so the Michigan document might be more inclusive in the range of traditions that are represented. And I would say that this becomes an issue not only about addressing vaccine hesitancy, but policies and procedures within hospitals. So my institution, Cincinnati Children's, has a mandatory influenza vaccine policy. It has not reached a conclusion about mandating the COVID-19 vaccine, but the EEOC has suggested that it may be acceptable to mandate the COVID vaccines as long as exceptions are made for both disability and religious beliefs, and reasonable accommodations are provided. And so part of the issue becomes then what is a what is a valid basis for an exemption as well as a reasonable accommodation. So for example, we occasionally have received objections to influenza vaccination around similar claims about the use of fetal cell lines. This isn't the case in the influenza vaccines, and so try to educate individuals about this. But it would be to say that individuals frequently also have other religious objections. And so then part of the question then becomes what a reasonable accommodation is. And in the case of the COVID vaccine, one of the potential accommodations would be to say if the dominant vaccine that one had available was the Johnson & Johnson vaccine, would be to make other vaccines available if individuals found them more morally acceptable. So understanding the arguments has implications not only for individuals, but organizations. And I would say that this is particularly an issue for us here in the United States because of the importance of religious beliefs to many of our fellow residents. So this is data from the Pew Research Foundation that looks at the percentage of individuals who say that religion is very important in their lives. So in the United States, 53% of individuals say that religion is very important in their lives, compared to 27% in Canada or 10% in the United Kingdom. Recognizing that 53% is also lower than some other countries, including India at 80% or Egypt at 72%. And we have a fair number of international patients who come from countries where religion is even more important. In terms of religious beliefs of Americans, just to orient you, on the left-hand side, this is a line graph. The x-axis is years going from 2007 to 2018 and 19. And the y-axis is percent of US adults who identify with a particular religious tradition. The majority of Americans identify with the Christian religious tradition at about 70%. At the beginning of this polling, about 50% of Americans identified as Protestant, decreasing more recently to about 43%. 24% Catholic to 20%. I would say addressing vaccine hesitancy issues in our community in which I live, Roman Catholic views are a more substantial concern, as about 25% of individuals in our county identify as Roman Catholic. Some gradual increases in the number of individuals or the percent of individuals who identify as agnostic or atheist, and increasing attention paid to the so-called category of nuns, or individuals who identify as nothing in particular, having increased from about 12% to 17%. But I think the important thing to say here is that although these individuals don't identify with a specific religious tradition, about half of them nonetheless consider religion important in their lives. And in terms of other religious groups, so I'm going to talk a little bit about the Jehovah's Witness tradition later. About 1% of Americans are Jehovah's Witnesses. 2% identify as Jewish, and about 1% as Muslims. The thing that makes addressing religious beliefs a bit more complicated is that there's a relatively low level of religious literacy in the US. So again, this is data that comes from the Pew Research Foundation. They did a poll that involved 32 fact-based questions about religion. It was a nationally representative sample that was increased sampling of some minority religious groups, about 10,000 respondents, and it was done in 2019. So their fact-based questions were things like, well, what's commemorated on Easter Sunday? Or when does the Jewish Sabbath begin? And variation in people's level of knowledge. So 81% of people got the question about Easter Sunday correct. Less than a third got the issue of when does the Jewish Sabbath begin correct. You know, this has implications in healthcare. For example, if I work in the inpatient setting, if an institution wants to be supportive of patients who are Jewish, maintaining their Sabbath obligations, you know, if staff don't know when the Sabbath begins, that becomes more difficult. Overall, religious literacy is relatively low. So about a quarter of respondents got 25% or fewer questions correct. In total, about 2/3 got less than 50% correct, and only a third got 50% or more correct. You know, if a C is 75% or better, only 9% of Americans would have earned a C on this test. And religious knowledge then is positively associated with a variety of different factors, including education, diversity of individuals' social networks, and certain religious affiliations. So interestingly, for example, atheists tend to be more knowledgeable about religion than Roman Catholics. And I think that this lack of knowledge leads in some ways to individuals' discomfort to asking about individuals' religious beliefs. And within the multidisciplinary team, I think that chaplains potentially have an important role. So there are different views about the primary functions or goal of chaplaincy, but colleagues at Cincinnati Children's have articulated a view of a religiously informed and relationally skillful chaplaincy. And that one of the central roles of chaplains would be to assess and interpret patients' religious and spiritual beliefs to other members of the healthcare team so that these beliefs can be incorporated into treatment planning. So religion is important to many Americans. It potentially informs their health behaviors. There are a number of barriers to ascertaining their beliefs in order to respond to them and incorporate them. And I think that chaplains have a potential important role to supporting the teams in that regard. In terms of talking about religion in healthcare, I think it's somewhat obligatory to talk about potential conflicts between religious beliefs and treatment recommendations. But we'll emphasize, even in situations in which those types of conflicts exist, that it's nonetheless important to treat patients and their families with respect. So the general thing to say is that parents should make decisions based on their children's best interest, but there are limitations of the best interest standard. So for example, the best interest standard doesn't incorporate parents, siblings, or the family as a whole's interests when those might be important. And it also doesn't provide a clear threshold for intervention in parental decision-making. So to say that healthcare providers or the state are justified in intervening if parents aren't making the decisions in their children's best interest is too low of a threshold. because the best interest standard is a very rigorous standard. So even Loretta Koppelman, who is a supporter of the best interest standard and would say that it can be used in a variety of ways, would say that its role in terms of intervention is once a decision has been made to intervene, that the best interest standard becomes important in deciding how to intervene. And so the focus in intervention, I think, is predominantly around harm. Doug Diekema has one of the seminal papers in this area and identifies 8 criteria for intervention. The first 2 criteria focus on the harm itself, that there has to be a significant risk of serious harm and that harm has to be imminent. The next several criteria focus on the nature of the intervention, that the intervention has to be necessary, it has to have proven efficacy and net benefit. And I would say that the net benefit criteria is one of the difficult criteria, can be one of the difficult criteria to apply, because I would say that it's not simply that the benefits outweigh the burdens, but that there's a significant net benefit. So some of the more difficult potential medical neglect cases we've been involved with relate to patients with cancer. And there are chemotherapy regimes that are of proven efficacy. There's good scientific evidence that they're beneficial, but that their benefits may be limited, say that they only have a 40 to 50% 5-year survival rate, and that they may have significant side effects. And in those cases, I would say that it is at times difficult to see whether or not the benefits sufficiently outweigh the risks to justify state intervention. That the intervention also has to be the least intrusive available. And then his last criteria are some more general claims. So one is that, intervening in this case would also justify intervening in other similar cases. And he articulates what he refers to as the criteria of publicity, that you would need to be willing to defend your view publicly, which I think is somewhat related to a claim about generalizability, but goes on to argue that most other parents would agree with the decision to intervene, which I think is a bit more of a complicated criteria in terms of protection of minority religious beliefs. To the other conceptual issue that I think is worth mentioning is thinking about what kinds of harms and benefits need to be considered. I think frequently there's a focus on physiological benefits and harms, death or disability in terms of harms. But there are other types of interest, in particular children's psychological and emotional interests and their relational interests that do merit consideration. So again, I would say that some of the more difficult cases related to medical neglect that we've encountered have been in older children, say 8 or 10-year-olds, for whom in order to effectuate the intervention, they'd have to be removed from their families and placed in medical foster homes, which would have significant emotional and relational harms. And it's not to say that those harms outweigh the benefits of prolonging their life, but certainly bear consideration in terms of shaping the interventions in order to limit those harms. And so this is from a statement from the AAP's Committee on Child Abuse and Neglect. So again, an emphasis on harm or risk of harm and significant net benefit, articulating some additional criteria. And again, I would say that reasonableness criteria are frequently difficult to apply because the standards for reasonability may be difficult to articulate. And so then you can think of different religious traditions that might have beliefs that are in tension with these views. So the Christian Science tradition generally rejects conventional medical intervention. So the Christian Science tradition believes that the fundamental nature of reality is mental rather than physical, and that the primary cause of disease and illness is disordered thinking, and that the appropriate response to illness is prayer, potentially through the assistance of a Christian Science practitioner. So in the use of conventional medical care with narrow exceptions for things like orthopedic procedures or assistance in childbirth, which are seen as mechanical, that conventional medical interventions are seen as diminishing the efficacy of prayer. And so prayer is appropriately characterized as an alternative rather than a complementary therapy. And so in this case, there are examples of, say, Jehovah's Christian Science parents who don't bring their febrile infant to medical attention, or a child who's developing polyuria, polydipsia, and weight loss, who has signs of diabetes, or once that diagnosis is made, reject insulin therapy in favor of prayer. And would say that this is primarily an issue about interventions of proven efficacy. So members of the Christian Science tradition will provide anecdotal evidence of the efficacy of prayer, but that their proposed course of action doesn't have the type of demonstrated efficacy that contemporary medical interventions do. And that provides a justification for overriding their preferences. The Christian Science tradition, the Jehovah's Witness tradition, on the other hand, doesn't reject medical care in general, but specific types of medical interventions, specifically blood transfusions. The justifications that the tradition provides is that receiving a blood transfusion is prohibited by their interpretation of Scripture, both of the Hebrew Bible and of the New Testament, and that they view receiving a blood transfusion as comparable to ingesting blood. And so within the tradition, receiving whole blood or any of its primary components is seen as unacceptable, as well as donating blood in advance of a procedure and receiving it at a later time. There are things that are left up to the discretion of members, which would include the use of fractions of any of the principal components of blood, including albumin, clotting factors, or immunoglobulins, as well as the use of cardiopulmonary bypass, as long as the circuit is not primed with blood, or the use of blood salvage, because the blood in these cases remains in continuity with the individual's own body. And I think it's important to say that although individuals within religious traditions may make religious arguments, that they may also make non-religious arguments. So the Jehovah's Witness tradition has historically made arguments about the risks of blood transfusions, particularly in the 80s and 90s. Their focus now is more predominantly on the lack of necessity for blood transfusions and in arguments about the success of blood conservation techniques. And then I think in terms of thinking about how this constitutes medical neglect, some individuals would say that these are parents who are making decisions in their child's best interest, and that they're worried about what might be categorized as a medical physical harm, that by receiving a blood transfusion, that they're affecting their child's eternal salvation. I think that that's a problematic construction, because that's not the way the tradition itself talks about their objections. and may be a projection of other religious traditions' views into the Jehovah's Witness tradition. I would more structure this as that the Jehovah's Witness parents are making a conscientious objection to the use of blood products, and in doing so, disqualify themselves in this narrow respect as the appropriate decision makers for their children, because one can conscientiously object to making decisions for oneself, but that doesn't extend to others. Would say that decisions for adolescents is more complicated, in that Jehovah's Witness adolescents may have, or adolescents who are members of the Jehovah's Witness tradition may have adequate medical decision-making capacity so that they, understand their situation, the risks, benefits, and alternatives to receiving a transfusion. They can give reasons for not receiving the transfusion and expressing a preference, in this case, dissent. I would say that the additional concern for adolescents is not necessarily about their capacity, but potentially their voluntariness. So within the Jehovah's Witness tradition, individuals who voluntarily receive a blood transfusion are disfellowshipped, what in other religious traditions might be called or referred to as shunned, and that because their social relationships with the other members of the tradition are severed, that this might undermine their voluntariness in decision making. So although I think that there are legitimate reasons in some circumstances to override parents' religiously based objections to medical treatment, I think it's nonetheless important to say that patients and their families should continue to be treated with dignity and respect, as UPMC's own literature reinforces. In the cases of transfusing Jehovah's Witness children, that can have a number of different components. One is to acknowledge that their parents love them and are trying to do their best in caring for their children. Some individuals have said that that it's been their observation that parents are actually relieved when the institution goes to court to receive a court order for a transfusion, and suggest that psychologically the parents really want the institution to override their decision making in order to prolong their child's life. I think that in some respects that may be disrespectful as to how traumatic having their preferences overridden truly is, or that it doesn't recognize the ambivalence in this decision making. That it's important to consider alternatives to transfusions. So local Jehovah's Witness communities have hospital liaison committees, which are committees staffed by lay members. They have a variety of functions, including providing information to providers or facilitating physician-to-physician consultation. So providers in different areas of the country may have different levels of experience in caring for Jehovah's Witness patients. And so they may be able to share information about bloodless techniques, which are of proven efficacy or facilitate the transfer of the patient to another provider, as well as arranging for pastoral care and assistance to the patient and the patient's family. I would say nonetheless, it's important to obtain the patient or the family's consent before contacting the hospital liaison committee in order to maintain the patient and family's confidentiality. And so a variety of different ways potentially to avoid transfusion, including minimizing blood loss and enhancing blood production. And I think that part of the ethical question here is what's the appropriate standard for these interventions. So frequently Jehovah's Witness parents will ask for the use of supplemental iron or potentially the administration of EPO. providers may be concerned that those interventions won't work within the time frame necessary in order to prevent a transfusion. But I would say that I think because this is complementary therapy, that the appropriate standard is, would they be harmful, as opposed to are they going to prove to be of benefit, so that being willing to administer supplemental iron or EPO, even if a team believes that they may not be effective in the appropriate time frame, is a reasonable intervention, particularly in order to maintain the therapeutic relationship. And then the last component that I'll highlight is individualized decision making. So individuals' tolerance of anemia is dependent on a wide variety of factors, including the rate at which the anemia developed. So that rather than using an arbitrary threshold like a hematocrit of 18 or of 12, that decisions are made based on the individual patient's tolerance of anemia, rather than, in some sense, arbitrary numeric thresholds. And so then the third area that I want to move into is to talk about accommodation a bit more fully. And in this case, in particular, focus around the neurologic criteria for death. So there are two contemporary criteria for death, either the circulatory and respiratory criteria or the neurologic criteria. There are, however, individuals in religious traditions that object to the neurologic criteria for death. These are a variety of patients who were determined to fulfill the neurologic criteria for death, whose family members nonetheless objected to the discontinuation of medical interventions for religious reasons. So I want to talk briefly about one particular tradition, and that would be the Orthodox Jewish tradition. I think it's important to acknowledge that there's diversity within the tradition, as well as among individual believers. But within the tradition, ethical decision-making functions predominantly on a juridical model based on precedent. And then within the tradition, there are a number of values that receive high priority. So both saving of life and observing the Sabbath are of high priority. Saving a life, however, takes priority over Sabbath observance. And so the situation arose in which a wall collapsed on an individual and the individual was buried under the rubble. Removing the rubble would constitute work and therefore violate the Sabbath, but could be justified if the man was still alive. So the problem arose, how much of the rubble do you remove in order to determine whether the man is alive or dead? Because if he's dead, then his body has to be left until after the Sabbath. And one of the potential answers was that you have to search until you reach his nose. And the alternative answer was that you have to search until you reach his heart. And the conclusion that was drawn is that that you only should search until you reach his nose because the nostrils contain the breath of life. And so within the tradition, some members of the tradition would argue that the only appropriate criteria in order to determine if an individual is dead is the cardiorespiratory criteria. In the same way, I think that there are other non-religious objections, or individuals who have religious objections may also have medical or philosophical objections. So in thinking about death, I think you can think about definitions, criteria, and tests. So the definition would be potentially the permanent cessation of the functioning of the organism as a whole, or the loss of integrated functioning. The criteria would be the irreversible cessation of all functions of the entire brain, including the brainstem. And the tests would be a physical exam to document unresponsiveness in the absence of brainstem reflexes, and then the apnea test in order to determine apnea, as well as potentially ancillary testing. And the objections, potential objections, are that there are gaps between the definition and the criteria, and gaps between the criteria and the tests, in that some individuals who fulfill the criteria, the neurologic criteria for death, don't fulfill the definition of death because they continue to have integrated functioning, including wound healing or symmetric growth or progression through puberty, and that individuals who fulfill the tests for being dead nonetheless may have some continued brain activities, particularly neurohormonal activities. And so some states have enacted accommodations for the diversity of views. The accommodations vary in a number of different ways. So the states are California, Illinois, New Jersey, and New York. They differ potentially in the types of objections that are considered, whether those objections are religious or moral, who needs to hold the objection, whether it's the patient themselves or whether it could also be a surrogate decision maker. So you could think here of the example of individuals who might have a donor card whose family nonetheless object to organ donation, and the question of whose views should take precedent. And then they also differ in terms of the scope of the accommodation. So in general, California, Illinois, and New York provide for accommodations of the duration of time between the determination that somebody fulfills the neurologic criteria for death and the discontinuation of medical interventions. Whereas New Jersey has a much broader accommodation. So New Jersey precludes an individual from being declared dead on the basis of the neurologic criteria if that would violate the individual's personal religious beliefs. And I think that given the diversity of views about the nature of death, I think that it would be reasonable to consider for other states to consider accommodating religious and potentially moral views in a similar way. I think there are a variety of potential objections to doing so that are nonetheless surmountable. So some people might claim that it's morally abhorrent to continue to provide medical interventions to a dead body. I would say that medical interventions are continued in several cases of individuals who are nonetheless dead, relative to organ procurement, or in an even smaller number of cases for pregnant women in order to progress the pregnancy. And so it's not that continuing to provide the medical interventions is in and of itself objectionable, but concerns about the lack of a justification. And I would say that would encourage people to consider the negative consequences to the family members as a potential justification for continuing treatment. Some individuals would argue that it's unworkable. In addition to New Jersey having the exceptions that it does, both Israel and Japan have similar exceptions. And I think that they have demonstrated that they're relatively workable. I think that part of the issue is that the numbers are relatively small, so that there's no central registry for brain death exceptions in New Jersey. San and colleagues have done a survey to try to ascertain the frequency at which this occurs. They identified hospital and health networks in New Jersey, contacted leadership of pastoral care or ethics committees. About a third of the people that they contacted completed an interview, and they identified 5 hospitals who had granted religious exemptions in the last 5 years. for a total of about 30 to 36 individuals. But even if this is a 3 or 4-fold undercount, this is still a relatively small number. You need to consider that 75, let me get the order of magnitude right. Yeah, 75,000 people die in New Jersey each year. So this would be a very, very small percentage of the total deaths. New Jersey does require health insurance providers to continue to provide insurance for individuals if they have religious objections. Some individuals have stated this would be an inordinate expense for the healthcare system. And I think it's certainly feasible to think about individuals obtaining riders on their health insurance coverage to provide this type of benefit, or religious traditions self-insuring their members against these claims. But I would say that I think that that would treat these types of religious objections as relatively anomalous to other types of ways that we manage health insurance. So I used to live in the West. You know, if you were a backcountry skier or a rock climber, you weren't expected to pay a higher health insurance premium given the higher likelihood that you might suffer a cord injury and require a higher level of medical care. So I think there would be some concerns about fairness of requiring individuals such as those with religious objections to carry riders on their health insurance. Individuals are also concerned potentially about the effects on organ donation. I'd say that the predominant effect would likely to be on heart transplant, which are generally dependent on donors who meet the neurologic criteria for death. I went back and I looked at the UNOS data for 2019 and normed it at the state level to 100,000 residents. It turns out that Delaware has the highest rate of about 2.7 hearts recovered per 100,000 residents. Pennsylvania is in the top 20 at 1.4. New Jersey is significantly lower at 0.96. But New York, which has narrower accommodations, is even lower at 0.65. So it's hard to imagine that New Jersey's accommodations are the predominant reason for its rate of heart donors. And then other potential objections in that it prevents access to scarce resources, particularly that other individuals who might need critical care would have limited access. I would say that I think that the COVID pandemic has demonstrated a substantial ability to surge critical care resources. And I think that the demands on the system would be relatively small. I'd say that I think that the predominant issue is on the provision of alternative sites of care. So for example, when I was in the United Arab Emirates, I had the opportunity to tour an extended care facility. And at that facility, there were 2 individuals who fulfilled the neurologic criteria for death. And so I would say that it would be important that there are other sites of care available so that individuals did not require care in intensive care units. I think that there's then the important to think about the correlative duties and rights of providers. I would say particularly in public hospitals and large academic healthcare systems, I think it's important for healthcare providers to develop the virtue of tolerance. And then I think that we increasingly encounter individuals with different backgrounds and experience. And it's important for us to be able to support them in their healthcare decision-making, even if their choices might be different than what we would choose for ourselves or our family members, but that there are limits and that it would be appropriate for providers to conscientiously object to providing treatments or interventions that are inconsistent with their core beliefs and values. But then it becomes important for the healthcare organizations to be able to provide alternative mechanisms for patients to receive treatment. So in the United States, religion is very important to many of our fellow residents and influences their medical decision-making. There are barriers to ascertaining, to talking about people's religious beliefs in order to be able to incorporate those into treatment planning, and that chaplains play an important role in order to help communicate those beliefs to other members of the medical team. That whereas it is in occasion justifiable to intervene to override parental decision-making, it's nonetheless important to continue to treat patients and families with respect. And that particularly given our increasing pluralism, that it's important to consider different ways in which religious beliefs should be accommodated. Thank you again, and I'm happy to entertain questions.
Thank you very much. We do have some questions we'd like to pose, and in the chat there is a link as well for the meet and greet, which will follow this lecture. So please join there, particularly if you have additional questions. Richard Freeman asks, the research on religious awareness and knowledge is intriguing. I wonder how prevalent is the lack of awareness or knowledge, how much of it is intra-faith, not just inter-faith. In other words, are some people indeed ignorant or misunderstanding of the requirements of their own religious tradition, and how does this lead to conflict in the context of healthcare, and how might it be addressed?
So it would be like, I have to go back and look at the data from the Pew Charitable Trusts about differences about intra and interfaith knowledge. I would say in the clinical context, the thing that I would emphasize is, different people place different levels of value about maintaining beliefs and behaviors consistent with their tradition. So some people, it's really important that they have orthodox belief and behaviors, and other people less so. And so a lack of knowledge about one's own tradition in terms of decision-making might be a problem for some people, and not others. Because frequently, or not infrequently, I'll hear providers say, well, we should get, a religious authority to come in and explain to this patient what their tradition really believes, which in some situations might be disrespectful because the individual might not actually care.
Mm-hmm. Thank you. And I guess a somewhat related question about how to practically address conflicting views is a question of the number of evangelical Christians who are objecting to the COVID vaccine, and yet this seems to be clearly contradicting an other-oriented, self-sacrificial, Christ-like view. Is it ever helpful to discuss these foundational misunderstandings with families, or is it best to let their version of faith be and not approach these as misunderstandings?
So I think that part of the question is what the primary driver there is, and whether or not the primary driver is, say, that individual's religious identity or their political identity, because vaccine hesitancy is also highly associated with political affiliation. And I think it is the delicate issue of trying to draw out and address people's reasons and objections in a way that is supportive and respectful in a provider-patient relationship, as opposed to the kind of bigger issues about addressing vaccine hesitancy and, say, mobilizing evangelical leaders to publicly speak about the importance of vaccination.
Thank you. There's a question as well about the immediacy criterion, that if a parent refuses an intervention that will affect a child over months and years, how should providers respond? Is there a difference in response depending on the immediacy of the effect versus a long-term effect?
So Doug talks about, so it is to say that if it's truly immediate, that one may be justified in intervening even without state intervention because there's not enough time to get state intervention. In terms of longer time frames, Doug's argument is predominantly that, well, if it's not immediate, you have a longer time period for negotiation. And hopeful, and he's optimistic that you might be able to resolve the situation. I would say that we, for example, have had issues related to, say, for example, a parent who was refusing treatment for pulmonary hypertension, which wasn't going to be an immediate risk, but over years would be a risk of premature death. And I think that the hard thing there is about what kind of intervention would really be needed in order to effectuate long-term treatment. So like a lot of the immediate interventions are discrete interventions. And a lot of the non-immediate interventions are longitudinal interventions. And so I think that part of that criteria may be smuggling in a degree of intervention required in order to effectuate the treatment, and that things that have to be addressed over a long time require substantially more invasive intervention.
Well, thank you. And I realize that we are now actually over time. I might pose one final question on behalf of our audience, but then also invite everyone to join for the meet and greet afterwards, as that Zoom connection is posted in the chat. But as a final question, thinking about COVID vaccines, about maybe research in general, do you think that there could be, that there is a lack of engagement of religious leaders or representatives during the research process for development of, for example, vaccines or other treatments? Could they be more involved in the research process, and could that be helpful with regard to then the public's understanding and acceptance of the fruits of research?
So I think I have to think about that a lot more. Like I would say that on like a basic level, I would say that objections to the use of fetal cell lines is clearly articulated. So I don't know that the involvement of religious leaders would necessarily change decision-making in that regard. Part of the question might be about whether involvement provided a higher level of comfort and may not change the research and development process, but because of a greater degree of familiarity, it provided religious leaders a greater ability to articulate the rigors of the process to their communities and provide them reassurance. So I think there might be ways that some ways that it might be ineffective and others that it might be beneficial.
Very good. Thank you so much. And with that, we are indeed out of time after 9 o'clock. But thank you very, very much for joining us, and everyone. And indeed, Armand, please join for the meet and greet at the link provided in the chat. Thank you.
Thank you.